My name is Thomas H. Strong Jr. I'm a maternal-fetal medicine specialist. We take care of high-risk pregnancies, whether it be from hypertensive problems, fetal abnormalities, genetic disorders, and just make a list. And we have or have recently seen patients with the disorders, from metabolic to genetic to cardiovascular. Well, I always wanted to be a doctor, probably because I come from a medical family. My grandfather was a dentist, my dad an obstetrician, my maternal grandmother, my mother and my daughter are all nurses. So it was kind of in the cards for me, but I was just fascinated by it even before I made the decision to pursue it. We typically see high-risk patients who have medical or obstetrical or genetic complications that require someone who has experience and training on whatever topic it is that is their complication, whether that's cardiovascular disease, lung disease, immunologic diseases, any of those things. The two most common complications are diabetes and hypertensive complications like toxemia, also known as preeclampsia. But we also see patients of advanced maternal age, which is a mother who's 35 or older. We take care of moms who have fetuses with known disorders or with certain anomalies that require our management to get that fetus as healthy as possible up through the pregnancy until delivery. Our treatments, I think, are set apart because we do maternal-fetal medicines. There are fewer and fewer general OB/GYN doctors who do amniocentesis, chorionic villi sampling, which is essentially a placental biopsy to find out if a baby has Down syndrome or some other abnormality from a genetic standpoint. Keeping in mind that we are a high-risk practice and we see some pretty scary things, I think there's still always the opportunity to kind of create a lighter atmosphere. Patients come to us that are just terrified about what may be going on or what is going on. And I think, having cooler heads and generating as best as we can a relaxing environment, I think it just makes things go easier for the mother. I think she wants to know that there's someone who's not afraid of what's going on, who's going to do his or her best to get her and her baby through it. I tell them that whatever we do is something that we'll do with their consent, with their understanding of what we're doing, of the pros and the cons, the alternative options. I always tell them, in 20 years, you want to make sure you can tell yourself and feel good about it that what you chose to do with any given pregnancy was the best thing for you, given the state of technology at the time when she was with us. Most of the time it's because the patient has a condition that the obstetrician hasn't seen before, or hasn't seen very often, or hasn't seen since they were in training. So they're really just trying to enlist us in, or asking us to be enlisted in whatever care plan is necessary to improve the outcome for both mom and baby, and family, really. I think they should start with talking with their OB who is sending the patient to us, so that they have a little bit of a head start of what their concern is and why they want to get us involved. And then we would expand on that once they get to us.